Dr. Christopher Jones is a consultant psychiatrist. He gained his MBBS from Nottingham University in 1983, became a member of the Royal College of Psychiatrists in 1988, has a law degree from Nottingham University and diploma in forensic psychotherapy from UCL Portman Clinic, an MD from UEA in 2011, and a diploma in statistics from Open University in 2013. His first consultant post was in North Wales in 1993 to 2001, where he became lead manager and head of the department from 1993 to 1999. He moved to East Anglia in 2001, and he is an honorary senior lecturer to UEA Medical School and visiting professor at St. George's University Medical School in Grenada. His research interests include confidentiality, legal duty to warn and protect third parties, interaction between legal and ethical standards of practice, adult ADHD, personal identity in patients who change their names, relational security in secure settings.
Well, I can't say I'm surprised by those figures in that show of hands. I think it was always going to be hard persuading psychiatrists to give up the idea of diagnosis. Not only because it's central to what we do, or what we think we do, increasingly I think it seems that diagnosis is the thing that doctors claim makes us unique and indispensable within the team, the thing that we do that nobody else does. So I guess we were always going to be fairly wedded to the idea of diagnosis. Later on I'm going to come on to why I think that's probably going to be a big mistake. But first of all, let's be clear. In principle, diagnosis is a good thing. If somebody's got a headache, knowing whether that's because they've got a migraine or because they've got meningococcal meningitis is important and useful. It really is a matter of life and death. But the important part of that diagnosis is the distinction between meningitis and migraine. Unfortunately, in the equivalent situations in psychiatry, we're still more at the stage of saying that the diagnosis is headache. And that really isn't the useful part of it. It's not useful in the same way. Our diagnoses are descriptive and not explanatory. The categories that we use, well, they're really fairly artificial. I doubt that any psychiatrist, I doubt that anybody in this room really believes that everybody with a diagnosis of schizophrenia has got exactly the same illness and that nobody else in the world has got it. Almost certainly schizophrenia includes several different conditions, sharing some features but not others. Some, maybe even all of them, probably overlap with other conditions that get different labels but might actually be part of the same thing. We're sort of in the position of doctors in the 18th century who classed lymphatic tuberculosis as being totally different from pulmonary tuberculosis because they had different symptoms, but then lumped it together with lymphoma because the two things looked the same. Until they could isolate the infective organism, this was like blind men describing the elephant. They were all looking at different parts of the same thing but didn't realise it. So, question for you. Does anybody here believe that there are exactly 22 different sorts of depression? Okay, well that's slightly odd really, because there are exactly 22 different categories of depression within ICD-10. And if each of those is a valid diagnosis, and if between them they cover the whole range of possible diagnoses for depression, then 22 different forms of depression, 22 different causes, 22 different treatments, 22 different outcomes, is precisely what we should believe in. And if that doesn't have any credibility, then neither does the idea that there were 22 separate categories to start with. Most people with an anxiety disorder have got symptoms of low mood. Most people with a diagnosis of depression have got some symptoms of anxiety. Are they different? Not different. Who really knows? And that's to say nothing of the distinction between mental disorders and normality. Who really knows at what point low mood, anxiety, obsessionality stops being part of the normal range of experience and starts to become pathology? We cheerfully attach diagnoses to things. Not only we're not really sure what's wrong, we're not even that sure that there's anything wrong at all. So it's no wonder that the diagnoses we come up with have little face validity. But I want to go further. I don't just want to tell you that psychiatric diagnoses aren't helpful. I want to say that they're positively harmful. So to do that, let's think about what diagnosis is for. I think it's got four functions. First of all, diagnosis is to suggest appropriate treatment. That's why we need to know the difference between the migraine and the meningitis to give the right treatment. But diagnosis isn't actually that much use as a guide to treatment in psychiatry. Hardly any of our treatments are diagnosis specific. Even terms like antipsychotic, antidepressant, we know only too well. They're of little use to define what the drugs do or what we use them for. We use antipsychotics as sedatives. That's what chlorpromazine was invented for. We use anticonvulsants as mood stabilisers. We use antidepressants, well, for just about everything, really. Despite that, we can see if we look in America how diagnosis in the form of DSM is being used by insurance companies to define exactly what treatments patients can, perhaps more importantly, what treatments they can't be given. And even which people can be patients at all and which people can't. And I think exactly the same is happening in this country. NICE guidelines are increasingly prescriptive. We've got less and less freedom to use clinical judgment to decide what sort of treatment people need to fit their needs. Some antipsychotics are licensed for use in affective disorders. Some aren't. It's not really about which ones are effective. It's basically down to whether the drug company thinks there's money to be made out of putting in for a license. But because the patient has the wrong diagnosis, some things can be used, some things can't. It doesn't matter what the patient needs, it matters what the label is. Ultimately, this is de-skilling psychiatrists. It makes treatment mindless. The patient has a diagnosis A, the NICE guidelines force us to give treatment B, and there's no room for any judgment or any discretion in that. And the final stage, for the moment anyway, comes with payment by results and clustering. All of psychopathology, all of human experience summed up into a handful of clusters. Every patient in each cluster is expected to get the same treatment and to respond in the same way. Well, that's certainly not how I want to practice psychiatry. But underlying all of that is the idea that the diagnosis is reflecting some sort of underlying reality. Secondly, people will say that even if we don't have the best understanding to base diagnosis on pathology, we need some form of classification so that we can do more research, so that we can make it better, these better classifications in the future. But I think that's only true, that's only going to work if the classification you start with genuinely separates things into the right groups. For 2,000 years, medicine used the humoral theory of medicine. Diagnose people according to the humoral theory. People had too much or too little blood, too much or too little phlegm, and that meant that they were sanguine or phlegmatic. Nobody working with that mindset, nobody working with that classification was ever going to discover the organism that causes TB. But they could cause plenty of harm along the way with all the bleeding and the purging that came out of the theory. And that classification was not going to help them move forward. Similarly in psychiatry, if we lump all of schizophrenia into one group, all of bipolar disorder into another group, the chances of ever finding out what the underlying processes aren't improved, they're reduced. It gets harder. Any potential finding about subgroups in there are going to be drowned out by all the other people that we've lumped in with them, and any genuine links between the people we've put into separate groups are going to get lost because we've allocated them wrong at the beginning. Effective diagnosis, migraine and meningitis again, means giving things their right names. But if you don't know the names, and if you don't even know which things go together in which groups, rather than guessing, rather than making names up, it's better to recognise from the beginning your ignorance and avoid classifications which are almost bound to be misleading. Thirdly, diagnosis is used to define what is psychiatry, what our business is and what it isn't. And that's a process that's had really profound negative consequences for our patients and for our profession. Public perception of psychiatry is that we're a pseudoscience, using technical jargon to cover up the fact that we don't really know what we're doing. Do the diagnoses that we use give us more or less credibility? Well, a few years ago, visceroptosis was a mainstream psychiatric illness. A few years before that, thousands of people were suffering from and getting treated for chlorosis. Well, good news. Thankfully, these terrible illnesses have all gone the way of smallpox. Thanks to brilliant medical progress, we've managed to completely eradicate those illnesses. Well, I'm sure that a Nobel Prize is on its way to somebody for that. I think we set ourselves up for ridicule when we make up new diagnoses every few years and abolish the old ones. When the American Psychiatric Association spends 15 years debating whether or not homosexuality is a mental disorder, and when we can't seem to agree ourselves even on the most basic features of the disorders that we claim to be treating. And that ridicule, it not only hurts us personally and professionally, it contributes to the marginalisation of mental health, people seeing it as not being a real illness, and the stigmatisation of our patients as not being really ill. Because, don't get me wrong about this, I'm not opposed to diagnosis because I don't think people are genuinely disordered. Quite the opposite. I'm absolutely sure that our patients have got real disorders and real problems, but too often they fall between the cracks in the classifications. They fail to get the help, not because they don't have problems, but because they don't fit the scheme of classification. We pathologise some people who would be better left alone, we exclude others who we could help because they don't fit. And meanwhile, mental health gets marginalised and trivialised, underfunded and cut back. And it's not just the public who reject our attempts at classification. Our patients routinely tell us that the labels we give them don't fit their experience of the problems that they've got. We always tend to call that lack of insight, but the truth is that if the patients themselves can't relate to the problems that we say they've got, we should be looking a bit more critically at the reasons for that and why we're giving them those labels in the first place. And finally, this seems to be a more recent development. A lot of people seem to be promoting diagnosis as being the core skill of psychiatrists, the one thing that we can do. Only doctors can make diagnosis, and you need doctors because without that diagnosis, services can't do anything. And a lot of the other professions seem to agree with that. When new ways of working came in, the other disciplines were very clear that they couldn't be making diagnoses. Well, I think that's wrong in a lot of different ways. Firstly, making diagnoses isn't difficult. It's not something that only we can do. The whole point, the whole idea of systems like DSM and ICD is to make diagnosis mechanised. Anybody can put in the data, turn the handle, out pops the diagnosis. There's computer programs that will do that for you. Secondly, I think that most professionals are doing this all the time, whether or not they use the D word. When a community nurse sees a new referral, carries out an assessment, decides on the treatment, provides the treatment, reviews it, and discharges somebody, they might say they haven't made a diagnosis, but come on, of course they have. And if that really doesn't involve a diagnosis, then the idea that diagnosis is important goes out the window. It's clear that most mental health services could do quite well in that case, without the bit that we do. Finally, it's said that diagnosis drives the treatment, but as I said before, that leads to the de-skilling of a profession where we just routinely, automatically follow the guidelines, the predetermined pathways. If we rely on diagnosis to define a role for psychiatry in the 21st century, I think we'll become irrelevant. Like homosexuality in the DSM, we'll define ourselves out of existence. So what's the alternative? If we give up 100 years of classification, what are we going to put in its place? Well, I don't think that the core skill of psychiatry is diagnosis. I think the core skill of psychiatry is understanding. Understanding people from different perspectives. That's what the biopsychosocial model is supposed to be all about. It means understanding people as individuals, not as examples of a standard condition. It means making sense of how their problems arise and how that interacts with everything else in their lives. We can get away from diagnosis. That's what we've always called formulation, a descriptive, individualised understanding of another person's situation. So, which of these tells you more about a person? This is a 30-year-old woman with attachment problems stemming from difficult early experiences, who's functioned well until the death of her mother, since when she's experienced low mood, social anxiety, transient suicidal thoughts. Or F32.10, which tells you more about the person, which gives you more understanding about the problems, which gives you a better idea of what's going to help, which gives you a better idea of the potential risks, which gives you the flexibility to tailor the treatment to the individual, which has got more credibility in the eyes of the patient or their family or the wider public. I think it's a no-brainer. I think 2 or 3 sentences of description tells us a lot more and is a lot more useful than any operationalised diagnosis. And it doesn't pretend to some sort of arcane knowledge about the underlying disorder that we don't actually possess. Even for researchers, the description is more likely to identify real similarities and real differences between groups of patients than the classification would. So, coming back to the motion in front of you, diagnosis does more harm than good. It's harmful to treatment because it forces us to give standard treatments to people who don't have standard problems. It's harmful to research because it misidentifies different things as being the same and similar things as being different. It's harmful to our profession because it has no credibility to the outside world. It's harmful to our relationships with patients because it prevents us from engaging with the issues they care about. It's harmful to our services because it allows society to marginalise the real problems that our patients have. And it's harmful to our careers because it reduces our role in the team to something that's mechanical and ultimately probably unnecessary. So that's my proposal. More understanding, less classification. We can do better research, regain our autonomy, regain our professional judgment, improve our patient image, our public image, improve our patients' engagement. Most of all, we can provide better treatment for our patients. All we have to do is ditch the diagnosis.
That's a very important point, which I would like just to, direct it to Dr. Jones. So a lot of people say, we do the same as any other medical colleague. Why is this attack on psychiatric diagnosis? Why don't you attack the inaccuracies in physical diagnosis, for example?
Well, I think there's plenty of problems with medical diagnosis generally, but I think my pitch will be a harder sell to an audience of general physicians because, whether we like it or not, I think general medical diagnoses do have more validity and more utility than psychiatric ones. They are, for whatever reason, at a much more advanced stage of understanding of pathology and causation than we are. So in a sense, the balance of risk and benefits in medicine, in general medicine, is rather different. I think in general medicine you do have a much better idea of what the valid classification is. My point is that in psychiatry, basically we're still guessing, and if we guess wrong, the potential downside of that is that we actually set back progress rather than facilitate. It is very much what we'd recognise as the Germanic school of psychiatry over the last 100 years. People like Bleuler and Schneider and Jaspers, who absolutely fundamentally insisted on the importance of description and of detailed, deep description and understanding of people's individual situations and circumstances. And that, I would suggest, is not helped by putting a diagnostic label on somebody. That is about the empathic listening. It is about ultimately about understanding, and it's about a rich, descriptive, flexible approach, whereas diagnosis increasingly is a tool that's used to impose a reductive, narrow, prescriptive approach, and I really don't like that way of practicing psychiatry. I think there's no doubt from everything you've heard today that we all know that our knowledge of mental processes, our diagnostic classifications are imperfect. The question is, does using our current imperfect system of classification, is that part of the solution or part of the problem? And I would suggest it's part of the problem. We know that psychiatry has a public image problem in terms of promoting ourselves to the general public, to society, and in terms of defending our corner and getting resources for our patients. And is our current diagnostic system part of that problem or part of the solution? I think it's part of the problem. We know that professionally our professional identity and our clinical freedom is being eroded and is being challenged. And is the use of diagnosis part of the problem or part of the solution? And we know that the relationships we have with our patients are not what we'd want them to be. We know that they're often antagonistic, they're often conflictual. And is the diagnosis part of the solution to that or part of the problem? I think I almost used a William Harvey quote actually in my earlier speech. He did say, listen to the patient, they're telling you the diagnosis. He said, take a detailed history, listen carefully to what you're being told, and the diagnosis will emerge. And I think we need to listen to our patients. They're telling us that the diagnoses don't work for them, and we need to listen to that. Thank you.
Thank you very much.